So week 8, we are going to be going over GI, GU. It's a really interesting week. Let me put in the box here. Apparently, y'all were having trouble trying to get the GI matching worksheet. I'm telling you, it's all the notes you need for this. It's in the chat box. Take it, download it, use it, study with that for your exam. That tells you all the different crazy things with the GI and the GU. Chadia, you're funny. Um, we this week that clinical pediatric assessment is due. Make sure I need to know what you're doing it on. I've got most of you, but not all of you. It's still at the beginning of the week. If you send it to me, I'll try to get you a look at how are you doing, all right? Is it on the right track? What would I change? I've scored some of them, send it back, minor things to change. So far, I'm getting some good stuff sent to me. It is the case study, which is the Evolve program, which is the pediatrics assignment exam. At the end of this class, on week 10, I think, it's the practice exam. So it's two different types. I had that confusion. When I first started this course, I had that confusion too. And then remember, always before we start looking for exam stuff, we do the NCLEX questions. So you do have 50 NCLEX questions due. So it's a lot of work this week, but next week there's no quiz. There's no test. So next week, just get all what you need to get in for your homework. Remember, homework is 20% of your grade. And if you don't get it done, I have seen too many students fail not getting homework in. Okay. So do the best you can. I'll work with you. Anything that comes up, talk to me. I'll work with you as long as I know before it was due. Okay. That's the key concept, before. So let's go ahead and get going with this week's PowerPoint. Anybody have any questions yet? Comments, concerns?
So just confirming, you said that next week we don't have an exam?
No quiz, no quiz.
Oh,
Next week is no exam.
okay.
Week 10 is your exam. Next week we'll be doing our reviews. So that's nice to think about. Gee, I don't have to worry about that. So we're going to start out with GU. I do it before GI. I don't know why. I just do them first. So gastrointestinal, genital urinary. What is genital urinary? Anything with the kidneys and urine, right? When we talk about children, most common disorder is when they get an infection. Why do kids get an infection? Well, they've got these short, wide open urethras. Little girls love to sit in nice tubs that are dirty, the water gets in there, or they like the nice tight little tights and cute little outfits and it just holds heat. All of those things can cause infection in little girls. Now, in boys, especially those very young ones, very susceptible, you have those children who are that are not circumcised, that these children will collect that white cheese-like substance, it's called, in the around the foreskin. And it's like this petri dish. And it grows bacteria, goes into the bladder, and it creates a lot of infection. So uncircumcised boys. And the one thing with children with all of these frequent urinary tract infections, you'll have some more than the others. Just make sure they finish all the antibiotics. That's the key. We want to make sure that everything's killed the first time. We don't want to hurt the kidneys by keeping that infection going. So, what would we teach a parent? What would we look for? Well, a kid who's incontinent, who's toilet drained, if you're smelling that urine, that's something. And then that urgency frequency, if they keep running, they're holding their private area, right? Little girls rubbing there because it's red and it's raw. All of those things are telling you something's wrong and it needs urinary workup of some sort. So we're going to teach those parents how to know about those things. We're going to tell them about simple things, washing hands, how to wipe from front to back, right? That's a big thing. They like just to go in there and wipe the back to front, and girls don't understand. Also, we don't think about urinary tract in the adolescent, but in girls, it is actually a pretty commonplace in adolescent girls who are sexually active. As nurses, we can teach them, one of the things you could do to, try to decrease the incidence of this is urinate immediately after intercourse. And that can help a girl, a woman. So once we determine urinary tract infection, we need to get a specimen. Now, everybody thinks you just put a bag on, get a urine, and that's good. Well, think about the little infant, under, year and under. They don't have a big immune system yet. And a urinary tract infection could cause even overwhelming sepsis and death. All right. That's how serious urinary tract infections can be. So we want it the first time to treat it, not wait several times because we're not getting a proper specimen. So young babies will get a catheterized specimen, a straight cath. We don't put a bag on because it collects skin contaminant and it's not accurate. And we want it the best we can. Parents can hold their hands, they can put the pacifier in their mouth, they can talk to their babies. The baby just does not like being held down. Is it uncomfortable? I've been catheterized. But it's over with pretty quick. So it's knowing it's the best specimen for your child. As they get older, yes, they can wipe them, they can urinate, they can catch a stream, and that's all right. But a bag urine isn't really a good specimen for that urinary tract infection. Now, suprapubic aspirations are done for your tiny, tiny infants. This is the one who is so small that there's no tube small enough to go into their urethra and get a specimen. And they take a needle right above your symphysis pubis and they go in directly and pull out maybe a half an ml of urine and they send it for culture. And of course, it's cleaned and all that stuff. But usually, these premature infants that we're doing that to, we'll give them something or they're on some sort of medication to keep them calm. They can go into the kidneys for those frequent kidney infections. We can go and put fluid into their bladder with a catheter and wash it and get the debris and all that stuff. We can do ultrasounds. Toddlers, frequent urinary tract infections, they're going to be going for avoiding cystourethropy. And that just looks at putting dye up into the bladder and does it reflux up into the ureters? Does it reflux up into the kidneys? And just looks at anatomy. Is it the anatomy causing those sort of things? In an IVP, usually think of kidney stones, and you think of that when and the older kids. Now, a couple terms that we need to know. Phimosis. This is when the foreskin on a male is so tight you can't pull it down. And again, the problem is you can't pull it down, you can't clean it, you're going to have more chance for having urinary tract infections. My grandson, I could not pull his foreskin down at birth. I waited several weeks, kept trying, and if anybody can do it, I can. Nope. We really had to get him circumcised. And he has had no urinary tract infections because of that. So again, we like to pull it down, we like to clean it. If not, then it needs to go in and it needs to be treated. Now, sometimes we can pull it down, it swells, and oops, we can't get it back up. That's called a paraphimosis. And what happens is the tip of the penis gets swollen and it's like a rubber band pinching it, and it's now losing blood supply. It is an emergency. What we will start to do literally is put cool water on it, try to constrict the vessels that we can get it down naturally, or a steroid cream, and we can pull it down naturally. That is our goal there. Hydrocele is basically fluid in the scrotum. These children, most of the times in kids, it'll go away on your young kids. Sometimes they're older and they'll need surgery to remove this extra fluid. Remember, any sort of genital urinary surgery, post-operatively, you have to be careful with what toys they're playing with. They can't be riding bikes. They can't be throwing hard balls. It could hit them in that perineal area, boy or girl, doesn't matter. And then, of course, bathing in a tub. When can you do that? Those are things to remember. Cryptorchidism is the testicles, not in the scrotal sac. One could be up, both could be up, and they could be in all different positions on the up area. It's one of the first things that pediatrician does, right? Goes in, checks the hips, of course, and that's next week's lecture. And then with this week's, it's looking at the testicles. Are they in there? And then if in the future they're not, I'm as a nurse, I would say, have you ever seen the testicles in the scrotum? Because sometimes they pull up, it's cooler, whatever. Remember, a warm environment helps the testicles sag. You'll be able to feel the testicles better. Now there's a hypospadias and there is a epispadias. It just means that usually the end of the penis is where the urethra, where you urinate out of, right? Hypospadias is on the vent side, so it goes down the vent, all right? Anywhere underneath the bottom of the penis. You look at that penis in that picture, you can see there's a surgical incision. That penis was filleted open. They made a tract for the opening to come to the end of the penis, and they used the foreskin. So no circumcision for these children, and we plastic closured it up. Usually, we like to get that done before 12 months old, before they're into that understanding genitals, before potty training. All of those things are important that we try to get it done before them. Usually, after this surgery, they have a catheter in there holding that lumen open, maybe 2 weeks. What do we do with that catheter? We make sure that's inside a diaper so you don't get urine everywhere. That's all we do with it. We don't touch it. Now, epispadias is just like the one on the bottom, right? Hypospadias. It's on the top of the penis. Same concept. You have to save the foreskin. You fillet the penis open. You put the opening at the end. You put the catheter in. It's there for 2 weeks. And again, general anesthesia. Knock these kids out. You're filleting a penis open. That probably would hurt. We're going to go into bladder exstrophy or coacal estrophy. It's when the body closes up with the bladder outside. We're going to see body organs, and we'll discuss that more with that one because they're all the same care with it. The abdominal wall didn't close the way it should, and the insides are born on the outside. And I've seen this in many different ways. All right. So, whenever we're talking about problems with the GU system, again, be careful post-operatively that nothing can damage it. They're not going to be riding a bike or a horsey or anything of that sort. Of course, are they urinating? Is there infection going on? Pain control. I'm telling you, their penis was filleted. There might be pain there, right? And then if there needs to be wound care, if that catheter is in, how to touch it, how to work with it, etc. And these parents are scared to touch that thing, right? Oh my God, it's going to hurt them. And, showing them what to do and how to do it and do it the best way. Now, renal biopsy, I always correlate this with a cardiac cath. There's similarities in it. It's the same sort of pre-op. NPO before, younger kids can stay NPO up maybe 2 hours before your infants, but usually it's 4 to 6 hours for the older child. They're pre-medicated, go to the procedure, and they take a needle and they stick it in the back under usually ultrasound, and they get a little specimen, a little urine out of the kidney, and they send it for a specimen. Now, in an infant, because it's so tiny, they're going to have to cut a little slice in there. So it's a little bit more invasive. Post procedure, what is our concern? Again, there's another pressure dressing there, just like cardiac cath. What are you looking for? Leakage of urine, leakage of blood. And because it could go into the peritoneal cavity, we're looking for abdominal pain, the swelling, because now urine or blood gets in there and irritates the bowel. We would feel that going on. And of course, you touch the kidney. What's the big thing we monitor? Intake and output. Now, I mentioned the cystourethropy, right? It's looking for obstructive uropathy. Now, the one word you need to remember is the bladder is also known as a vesicle. Means it's a space that holds fluid or something, a vesicle. This is a bladder, okay? So We can have vesicle, ureteral vesicle, which means from somewhere in the bladder to the ureters, there is a kink, or it could just be in the ureters. It could be one kink, two kinks, one side, two sides, one kidney, two kidneys. It could be a little bit of anything, or several different types. So that, as I said, can cause problems with urine output on, those kinks going on. Now, nephrotic syndrome, I'm going to say this 2 times so you know it. This has nothing to do with renal failure. The kidneys are working. This is not renal failure. This is the kidney saying, protein, yuck, I'm getting rid of you, and urinate all the protein in the body out. All the protein goes in the urine. So, proteinuria is there. Where else do you have protein in your body? In the blood. It's also called albumin. It's the same thing. So there's no albumin in the blood. So you got to be careful with drug dosing here. And because of the difference in pressure, intracellular, extracellular, is pushing fluid into your extracellular, into interstitial tissues, and you're having generalized edema. And of course, massive urinary protein loss. That is nephrotic syndrome. So we're talking about something to do with the kidney. We're talking about urine. 3 things a nurse must remember, anything that has to do with fluid. How do we measure it? Intake, output, and a daily weight. Okay. Children with nephrotic syndrome, they are immunosuppressed. So a risk for infection, right? They don't have appetite because the inside of their mouth gets swollen, and they bite their tongue, and they get sores because their teeth in their mouth. So they lose their appetite only because of that extra swelling. So what do they need to be on for life? A salt restriction and a fluid restriction. Now, if they have a moment where the nephrotic syndrome is out of control, we give steroids, and steroids decreases the inflammation, and it helps decrease some of this proteins being excreted. So again, our goal is to stop that protein from going away, is to reduce that all that fluid in the tissues, bring it back into the bloodstream and get rid of it. You know what the easiest way how to pull fluid out of the tissue into the bloodstream is? Well, let us know albumin has no protein. Let's give some 5% albumin into the blood, and then wait about 20 minutes and give a diuretic like furosemide, like Lasix. It'll push it right through. It sucks it out and gets rid of it. And it's one of the things that we do to eliminate that swelling and that being uncomfortable thing. So again, priority, intake, output, daily weights. Now we've heard of rheumatic fever, and we heard that it's due to a strep infection. Well, guess what? Here's another one. Not only could you get rheumatic fever, acute glomerulonephritis. That means it's messing with your kidneys now. And it's usually anywhere from 10 days to 3 weeks out that we see the body respond. And what would be the symptoms? What is glomerulonephritis? Well, the glomerulars in the kidneys are all inflamed, and it stops urinating. So you're not urinating. Where's the extra fluid going in the body? You're not urinating, so you're getting swollen. Anything with kidneys and swelling, high blood pressure. And with glomerulonephritis, specifically to it, is periorbital edema. So we talked about nephrotic syndrome is generalized. Glomerulonephritis is periorbital edema. You might see blood in the urine and protein in there also. So how do we know if it's glomerulonephritis? Well, do you remember that blood test, that ASO titer, the streptolicin titer? Well, if it's positive, you've had a strep infection, and you can go ahead, treat the strep infection, and we can get rid of this completely. Now, if it goes on for more than a year, it becomes chronic, and it's no longer an acute, like an incurable type thing. It'll become, you're going to have glomerulonephritis. So again, fluid problems, intake, output, daily weights. And because this is the kidney and it's swollen and inflamed, we're going to be measuring abdominal girth. That's just part of it. Same thing as nephrotic syndrome, low sodium, fluid restrictions, and again, they're immunosuppressed with this. Wilms tumor, it's a kidney tumor, right? We've learned about this, and this is in boys, and that means do not palpate the abdomen with this one. We've talked about it. Now, renal failure. Some kids are born with it, and some kids get it. Do you know what the biggest cause for acute renal failure in children is? Dehydration. Dehydration is huge in children. That means the blood's not perfusing the body organs and especially the kidneys. And what happens is the kidneys shut down and go into acute renal failure to try to save the kidneys from being damaged. So again, they stop urinating, and it's all of the signs and symptoms in acute that you would see in a chronic renal failure. BUN's up, creatinine's up, not urinating, metabolic acidosis, electrolytes, all of those things. If we correct the cause of acute renal failure, and then it all goes away. I've seen it actually due to ibuprofen has caused renal failure and a very dear friend of mine. And I couldn't figure out, I was so frustrated. It was an NSAID that caused renal failure. 3 days after stopping them, all of a sudden he started urinating. BUN creatinine started coming down. He was set up to get a shunt to start dialysis. That day, he started urinating. So, again, dehydration is the one that caused it the most. Chronic is when about 50% don't work and it gets worse and worse over time. Older children get hemodialysis. It could be due to you're born with it. It could be hereditary. It could be because of infection and disease. Also, anaphylaxis and lupus will kill any organ. It can kill kidneys too, right? So with chronic renal failure, again, in any condition with a child, you always want the child to be a child, no matter what. I've worked with the dialysis children when I was doing clinicals, and I'd walk in and I'd see the dialysis nurse with a guitar and two other kids, one that had a banjo, one that had a guitar, and they're playing and singing while dialysis is going on. They made them be kids, even in having dialysis. And I'll never forget that. I think that's the sweetest thing. Remember, in kidney failure, we worry about those red blood cells because they're erythropoietin, it's not being secreted. Remember, we can give injections of it to try to help that chronic low hemoglobin hematocrit. Low hemoglobin, low hematocrit, no energy, no oxygen. We want that kid to have as much energy as they possibly can. Now, infants and young kids cannot get hemodialysis, and they're born with things like prune belly. That means and not all of them, but many of them, their kidneys don't work. So they need something to filter the toxins in their body. So this is a great, great, great picture. The tube that's going in, it's sort of hanging down there to the side, is put in surgery. And our goal as nurses, and I used to be certified in the hospital to do peritoneal dialysis. I had to go through this course. And our goal is to keep it sterile. That means we put hats, masks, shields, everything on, gowns, of course, gloves, and we try to keep sterility in it because the biggest problem with this is infection getting inside that peritoneal cavity. There's no other place for a kidney to be. You ruin the peritoneal cavity. What else is there? Nothing, because they can't go hemodialysis. Okay. So, what do we need to look for and to keep that child safe? Well, we're looking for any tenderness, any redness, especially if we start seeing different color secretions coming out of that tubing. Now, what we do is we take this warmed what they call diastolate fluid, a mixture of electrolytes and glucose or whatever that nephrologist wants. It's warmed and it's put inside that abdomen, and it's 100 mLs, 200 mLs. It stays there for 20 minutes and then they drain it for 20 minutes. And that is a cycle. And usually they'll do 8 to 10 cycles at night so the kid sleeps with this. And this child can stay home and get this done until they're old enough to get a transplant, because that's usually what will happen. So, what best describes acute glomerulonephritis? How do we get it? Rheumatic fever, glomerulonephritis, same organism.
See?
Is
It
it
has
B?
to do, it is a strep infection. This another one. Remember, rheumatic fever will kill heart valves and create all these things. It'll go away with antibiotics. Same thing with glomerulonephritis. Your kidneys stop working because of the strep. We treat the strep, and most of the time that infection goes away. Thanks for trying. Appreciate it. Now, GI, you're going to hear some things you never heard of before. All right. This is where I think the hardest chapter in children is, because you'll see as we start going. So remember, GI, mouth to anus and all the organs connected in between. What does the mouth to anus do? It gives us nutrition. So, of course, we'll talk about nutritional disorders. Cancer, HIV, sickle cell, cystic fibrosis, low birth weight, all have a problem with nutrition, and they have to be dealt with all differently. All right, celiac disease. This is your small intestines. And the in celiac disease, it doesn't like something called gluten. Gluten is something that is in wheat, rye, barley, and oat flour. That means anything breaded, any noodles, breads, cakes, cookies, everything that's good, it's all, sweet stuff is all, gluten. Now, this can be treated very, very well. The problem with celiac disease is that the body cannot digest fat. Now, remember, fat's your highest calories of all nutrition. I believe it's 9 calories, and protein and carbs are 4 calories per gram. So it's a big difference. So these children, they don't digest fat. And one of the big telltale signs is pale, bulky, extremely foul smelling stools. Okay. Sort of similar to cystic fibrosis, but not completely. All right. There's differences here. These children will have abdominal distension due to fat, and they will be tiny, and they're going to need those fat vitamins given to them. Okay. Now, this is a good time in their lives with celiac disease, because grocery stores are now putting all over labeled things gluten free, gluten free. And rice flour is now something that's ready available to the public, where it wasn't. So we can make our own stuff if we had to, but many of these grocery stores do today. Now, food allergies. I'm sure you all have an intolerance to something that you don't like, and it creates issues and problems for you. I mean, the biggest one, lactose intolerance. Those people who can't have lactose because they'll get gas, etc., taking it. Now, remember, when you have a food allergy and you have to withhold a nutrition like milk, remember children get vitamin D and calcium there. They need to get it in another way. And it's something that you forget about with that we need to teach parents. Vitamin D, go out in the sun. Calcium, what else can you give them calcium with? GI dysfunction, you don't get enough food because of whatever reason, you're going to grow. Your growth is going to be stunted. So there'll be growth failure. You're spitting up, you're not getting nutrition. You have vomiting, it's losing it. If you're diarrhea, you're losing it. So again, it's all to do with nutrition, growth, and cognition here that we want to keep. I mean, even when a child has dysphagia or difficulty eating, and like Pierre Robin is one of those syndromes, and the George syndrome, tiny little chins and they can't use it and they don't know how to manipulate it, and that difficulty, dysfunctional swallowing. You're not eating, you're not getting calories, right? Now we talked dehydration and how serious it is. So how are we going to take care of this and what causes it? Well, that was insensible fluid loss could be a fever. That's why if you have a fever, have a child with a fever, make sure you're giving them small, frequent amounts of liquid and whatever they want to drink, give it to them. You know, you think it's milk, they can't because it's phlegm. No, that's what they want. That's what they'll drink. Give it to them because the fluid is better than not getting the fluid. We know that GI tract, vomiting, diarrhea, urinating a lot. Maybe you had a lot of something that creates diuresis. You're urinating. And of course, in diabetes, you have your ketoacidosis. And of course, burns. It just eats up tissue and all that fluid. Now, I absolutely love these pictures of these babies. This is classic baby dehydrated. Look at the color of them, number one. They're pale. The top one, the ears are not even pink, they're pale, and it's almost green looking underneath there. Fontanelle is sunken down like crazy. You can see all of the different bones in his head. That number one with an infant, I don't even have to listen to a heart rate. I know that they're not feeling well. Well, okay, what else would I see if it wasn't an infant and they didn't have that beautiful fontanelle to check out? Well, elevated heart rate, decreased blood pressure, prolonged capillary refill, decreased urine output. Infants crying with no tears is a big red alert. No fluid to even use tears, and of course, skin tenting. So, what is our goal for a child looking like that? Something orally isn't going to catch them up quick enough. Yeah, can you give them orally if they're not vomiting? Okay, but let's get some fluid bolus in them. Get yourself a metabolic profile. Where is the sodium, the carbon dioxide, chlorides? Where is the potassium? Where's that glucose? Glucose could be on the floor they're not eating, okay? So get that basic metabolic profile and then start the IV and maybe IV NPO. Let's get it going. Remember, in nursing, for any age patient, no potassium until they void or until you get a level from the lab, and do not ever bolus with anything with sugar. Okay, so normal saline, Ringer's lactate are fine. Hospitals always use 0.9 normal saline. Give them a bolus, 10 mLs per kilogram, 20 mLs per kilogram. That's normal. Repeat if and they give you guidelines for it. If there are vomiting, of course, they'll get an antiemetic. But the goal is let's get that fluid back in that body. Let's get that kidneys perfusing and let's prevent that renal failure, right? Now you get these kids in the hospital, just about to go home. They look like that when they came in. How would you know that all of your work helped? Well, number one, of course, they're going to look better. But one of the big telltale signs is a weight. What did they come in and what do they weigh now? That kid came in dehydrated. When they're going home, they're going to be a lot heavier than what they came in because now they've got that weight back on them. Again, anything with fluids, intake, output, daily weights, going to give you the sign. You know, intake and output, we can check in a lot of different ways. I've gone over them. And then diarrhea could be due to germs. It could be due to something the body is just it just has normal stress diarrhea. I mean, there's all different type of diarrhea, but we treat it all the same. Now, the thing with vomiting, we make them NPO when they're vomiting because they're vomiting. With diarrhea, if there's no vomiting, you can always give oral replacement, oral electrolyte replacement, Pedialyte, Powerade, Gatorade, all of those things can be used, for that, all right? Now, when we can, and as a child tolerates, giving them a diet is what we have to do. If you only gave them liquid, what's going to happen to the stool? Is it going to have something in it to firm it up? No. And do you know what doctors order? Probiotics once a day until the stool is firm. And that's treatment for your diarrhea. I mean, if they're really severe, really lethargic, again, you're going to get your basic metabolic profile. You're also going to IV and then, of course, give oral at the same time. Again, patient conditions. Now, one of the things that I always found interesting is children coming in. I've seen them from 10 months to 3 years, where parents say he hasn't moved his bowels in 7 to 10 days, 2 weeks. And I'm like, what? Did you miss something somewhere? They go, no, they've been with me and no, nothing. You do an x-ray and their whole colon is lit up with stool in it. It's like, okay. And you feel the tummy and actually you can actually feel the stool in there. It's so full. You know, the only thing a child can control is their bowels. They can hold it. Many times it's because they want some sort of, you know, attention, believe it or not. So it's something that the only time that you would give an enema to a child is to break that apart and get it going, but we don't ever give laxatives. We do not give enemas routinely ever to children. You know, the only thing, if it was one of those really hard cases, maybe a little Miralax type thing. It's like a Metamucil for children. But that's it. We're not going to do more than that. Now, constipation of the newborn. One of the things that we look at birth in a newborn and we pay close attention to is their stools. It's very important that they have a stool within 24 to 36 hours after birth. If they do not, there's something going on. It can be hypothyroidism, cystic fibrosis, or it could be some sort of intestinal blockage. The blockage here we're talking about is Hirschsprung's, but we'll talk about that in a second. So, no stool on an infant. You're going to be testing a sweat test, you're going to do a thyroid panel, and you're going to do an x-ray looking at that tummy. So constipation in infants, it's more in the bottle fed with formula than it is with breastfed. It's just as the way it is. Also, older kids, and I put this here because of my South Florida roots, you know, how do we go and we get these children having a stool more frequently? Good old black beans work really well. And I thought that was interesting living in Miami. Also, whole grains of all sort can do help. Again, increasing fiber. Pinworms and enterobiasis is something that we don't know about until the middle of the night and the kid is not sleeping and it's moving all over the place and his butt itches like crazy. It's anal itching and they're scratching it down there. It's like, what's going on? Well, you're to instruct the parent, get a piece of scotch tape and a flashlight, open up the buttocks and put the scotch tape around their anal area, pull it off. And you might see a little tiny little worm like that. And that is pinworms. How do kids get it? Well, if their nails are long, they like to play outside in the dirt, sandboxes, all of those things. That's where these things are. Once you confirm a child has this, you need to check the whole family because it's that contagious. All right. Ugh, right? Peptic ulcers, yes, kids can get them. I've never seen a kid have to go to any surgical thing with it. But, you know, kids are little worriers and they do get that little acid stomach. So giving them something like ranitidine, Pepsid, which is today, it does reduce that gastric acid, and that's usually all they need with a little diet change. Liver diseases can be due to almost anything. And no matter what the liver dysfunction is, it means that the liver's not secreting fat the way it should for digestion. That's what the liver does. Its purpose. Yes, metabolizes, you know, our drugs, all that, but it produces that's the liver. The bile comes out of the from it, and that takes care of all of the fat, right? So if they have a liver problem, they're not digesting fat. So how would you supply them with their caloric intake? Increase carbohydrates, increase proteins again. This is another condition where low fat, because too much fat will make all of that abdominal cramping and pain. Now, there's something called biliary atresia, and A is without, means the liver's not connected to the common bile ducts, connected to nothing, and bile is just floating in the system. Can you imagine? What would you see? Well, the bile can't go anywhere. You're going to start seeing the skin turn yellow. You're going to see the eyes turn yellow. But before that, you're going to see very pale, whitish stool. There's no bile in it. So the color changes. It's usually the first thing that we check. This will need surgery. Now, Hirschsprung's disease. This is part of that constipation of that newborn. See that big pouch at the end of the colon? You see like a tiny little ending? Well, that outpatching is what we call a congenital aganglionic megacolon. Aganglionic, no nerve cells, no peristalsis, no feeling. It stretches. The baby doesn't know about it, doesn't feel it. There's no nerves, no stool. And if it does get enough backed up in there, you might get a little bit to squirt out of that tip on the end. And this is when we call it a little bit of ribbon-like stools. Is the only thing you may see there. Down's children, this is another thing they get. Acute lymphocytic leukemia, hypothyroidism, cardiac problems, and Hirschsprung's. Poor Down's kids with all of these things that you have to be concerned about. So how do we diagnose it? Well, they're not stooling. All right. Oh, I saw a little ribbon. All right, let's go ahead and let's do a biopsy. Find there's no nerve endings. And we'll do one of two procedures. Either we take out that piece and bring up the good end, put a colostomy till about a year old, or sometimes we can take out that bad piece and connect them. It's called a pull through procedure where we never have a colostomy and it ends up. Depends on where it is, how much space you have, et cetera, et cetera, et cetera. Know that post-operatively, there'll be no rectal temperatures on this child either way. Leave it alone. It's tender, and it would be something we wouldn't do. And of course, you've manipulated bowel. These children's going to take a lot before we start feeding them. Most likely NG tubes to come out with, and then slowly we'll clamp the NG tubes, and then we'll start maybe clear liquids a little bit. Very, very slow feeding these children. Now appendicitis, same thing as adults. McBurney points, right lower quadrant, you hit the bottom of their foot. Yes, it's going to hurt. They can't lift their leg up, all of those things. We diagnose it with an ultrasound. If it's still an appendix that's there and it hasn't ruptured yet, they go up to the OR, we'll start an IV, we make them NPO and give them an antibiotic, just preoperative safeguard, and they're done. They're usually home the next morning, that quick. Sometimes if it's early in the morning, they're home in the afternoon. But if it ruptures, we got a different story. All of the debris and toxins from the cecum and the appendix just squirts into the peritoneal cavity. Your priority care in appendicitis, antibiotics. This is the one, antibiotics is your priority because this child is full of infection. So nothing to eat, an NG tube to keep that GI tract decompressed, rest those intestines. They're angry. They've been spewed with toxins. They don't like it. Giving them those IV antibiotics, giving them pain control to cough, turn, deep breathe, use incentive spirometry, get out of bed, ambulate, all of those things. We want to prevent, and help those intestines to start working. You're going to be watching that CBC as the white count coming down with all those antibiotics. And this is the one DHIS I saw where they had did a little bit of an open appendix, remember that tissue underneath is all infected. So when they closed it, they're closing two infected areas. So the chance of it opening up are real. So assess the wound. Big thing. Assess the wound. And as I said, good pulmonary care. I've done things from kids blowing on those little windmills to older kids with a straw doing spitballs against the window, 6 feet away. And the kids love doing that with me. I worked the night shift, so I could do that stuff. Now omphalocele. This is just like bladder exstrophy. It doesn't matter what organ, something is on the outside that should be on the inside. So, what is our goal? Well, the insides should be inside, and it's not, so we're worried about infection. So, cover it with a sterile, wet saline dressing, and they'll be in a warmer. They'll be on their back. They can't be on their tummies. They're not going to be squaddled because we have to keep watch on that thing. And we're going to give antibiotics as a prophylactic to be sure. Usually within a couple days, they will put it back in. I've seen many omphaloceles, and they tend to make what we call a TP out of it and hang it on a IV pole. So it's like forcing it to go straight down into the belly. And they come in and maneuver around the skin edges, trying to stretch it. And when the belly, the abdominal wall, and when they feel they can do it, they go to surgery and they close it up. And they end up, yes, there's an incision, but their insides are inside and they still work, whether on the outside or inside, whether a bladder, whether a liver, intestines, a stomach, whatever it is. Now, intussusception. This is when the intestines suck up into each other and it doesn't come out. These are usually those children, they're usually toddlers. The youngest one I've seen was about 5 months old. Very difficult at that age to check and see what it is. Usually your toddlers come in, parents are holding their children, and the kids' legs are going back and forth and they're screaming and you can't console them. And if you took your hand and put it on the abdominal wall, it's going to be really tense. Now, occasionally, that intussusception, that telescoping pulls out. The pain stops and the kids are fine. Now, if it doesn't do that, if you check into the diaper or even in their underwear, you're going to see current jelly stools, like a little bit of this jelly with a little bit of blood streaks in it, maybe. That's intussusception. Remember, ribbon stools, that is Hirschsprung's. Current jelly stools is intussusception, okay? And usually it will come back by itself. Um, I've seen one case where they had to go in and cut that piece of intestine out. It wouldn't come out. We tried to give, an enema under fluoroscopy by radiology to pump it out. It didn't work. They had to go in, they had to do surgery on that child. But one in all my career. Mecyldiverticulum. I call this like a little outpatched skin tab in the small intestines. But in that little skin tab, it's highly vascular, huge blood vessel. And sometimes it rips and it creates blood in the GI tract. And you're going to see bright red blood, but it doesn't really hurt anywhere. Maybe slight tenderness, but nothing really significant. They do surgery, they fix it, and these kids do well. IBS, mouth to anus or bits and pieces, right? All it means is an inflamed bowel disease. Ulcerative colitis, one of the big signs and symptoms, profuse diarrhea. Many times, diet will take care of it. In acute phases, steroids to help that inflammation. Sometimes Crohn's will be placed on biologics. And, it all depends on child. A prognosis is how are you in maintaining that diet, and again, it's stress related, et cetera, et cetera. Now, short bowel syndrome is when during the course of a child's life, a piece of their intestines die, and then the absorption of the intestines decreases. It can't, be as absorbent as it can be. So these children are apt to be depleted, right? They're going to be failure to thrive. I had one little girl, Jessica was her name. She was 8 or 9 months old at the time, and she came in for her second stage of a hypoplastic heart surgery. Okay. After surgery, they gave her a little ND tube, ND, into her duodenum, little tiny little drip of formula to keep her bowel moving. Well, her belly didn't like it, her intestines didn't like it. And what happened is her intestines went to necrotizing enterocolitis, which means it died. So now we are spewing contents into the abdominal cavity. Well, they brought the girl to surgery. They removed, I don't even remember the number of a small intestines, 48 centimeters. It was some like unbelievable number. Small intestines is where all the absorption occurs. So you can imagine this girl was a cardiac with a short gut or a short bowel syndrome. She ended up on with a Broviac, like that little boy, that tube up here, that central line. She would get hyperalin lipids at night. During the day, she could eat when she wanted, but she would also get in her G tube feedings. And they tried to give her as much nutritional support as they could. She was always skinny. You know, I knew her as a baby. The last time I saw her, she was 18 years old. She was part of a triplet group. And she came into the ER and she was actually looking for me. Something she had heard her needed an X-ray or something, and she knew I was down there. Her and her mother and her two brother and sister triplets came in, and you could see the difference. Jessica was skinny, tall but skinny, and she had cardiac problems. And the other two, you'd see they're bigger, heavier kids, but it was because of this short bowel syndrome. Remember, hernias, the big thing is if you can take them and squeeze them, push them in and out, they're good. Whether they're in an umbilicus, I love pushing those little belly buttons in and out. I think they're fun. Or sometimes they're in the inguinal cavity canal. You can push them in and out. If it's painful, you require surgery. It's strangulated. It means the blood supply is turned off. It's squeezing it and twisting it, and the nerves are telling you, ouch, do something now. Now, do you wonder why you do a rectal temperature at birth on newborns? They say because you need a accurate temperature, right? Well, they're checking to see, do they have a rectum? Look at that picture. That little baby doesn't have a rectum. You know what happens is they will do surgery immediately, give them a colostomy, and then they'll try to reenact some sort of anus multiple surgeries later. They do try to create an anus for this child, but again, it takes a lot of stuff going on. You know, remember, not only is there no anus, sometimes we have connections between the rectum and the bladder or the rectum and the vagina. I have seen stool coming out of different places. Again, mostly nurses notice those sort of things. So if you ever work newborn ICU, be aware something that could happen. All right, now children, they love to get into everything, don't they? You know, being a triage nurse that I was for about 10 years because I had a lot of experience, um, I know that the biggest thing children love to eat was their vitamins. And there's really not a problem with the vitamins because what you don't need, you just urinate out. There's not like a toxic sort of thing with it. Of course, ibuprofen and acetaminophen, we worry about those things. The other things I've seen is grandma's blood pressure pills. I have seen them rat poison, and I've seen, of course, those Tide balls, which was a big thing. Some of the younger kids got into them too. And again, you know, remember in older buildings, we worry about the paints and lead and whatnot. That's why today if you're buying houses, whatnot, they always in older places check the paint for lead, especially with young kids. What do kids do at windowsills? They stand there and look at the outside, right? And they bite on it with their teeth. And if it's got lead, it could be lead poisoning. Now, vomiting. All right. Vomiting is either a dribble or it's an across the room. Now, usually the ones that parents are most concerned about is the young kids vomiting. My first question always, tell me, has he vomit? Is he dribbling here or is it going, across the room? Now, if it's a little dribble, okay, probably a little reflux, a little GERD, something of that sort, you know, but still they're vomiting. Check to see how badly dehydrated they are. Check a fontanelle, check a heart rate, blood pressure, of course, all that. All right, they're vomiting. They need fluids. Number one, get your metabolic profile. Start your IV, give a bolus, no dextrose, no potassium. You're going to give them that antiemetic and you're going to keep them NPO for a little bit. And then you're going to introduce. On an infant, you would give them some Pedialyte, let them start. On an older child, you might give them a popsicle. I mean, they might want that, or maybe a little Gatorade or Powerade. Reflux is that burning up my esophagus that hurts. Older people get it, younger kids get it. Older and younger ones, if you hear them coughing a lot and burning in their chest, that's reflux, okay? They're burning an esophagus. Now, in infants, it's the spit up and that loss of calories that we're concerned about. They don't have a lot of, room to not get calories in them. They need them. So, how do we take care of reflux in infants? Well, initially, we'll make sure that they're not overfed, they're burped properly, and they're sitting up after feeds. If they're doing all that right, we're going to add some rice cereal to their formula or breast milk. Now, they're not going to get nutrition from rice cereal, but it's going to hold the milk down so they gain nutrition by not vomiting, okay? Now, there are times where the reflux, not the younger kids, but more the older ones that are having this reflux on every single med an adult takes. Think of an adult reflux med, children get it, but in a children's dose, they all are okay. But sometimes that esophagus is getting so bad, they do something called a Nissan fundoplication. And that fundoplication takes the top of the stomach and pulls it over. This child can't vomit anymore. They use this a lot when they put in gastrostomy tubes, prevents vomiting. Now, the other sort of vomiting is across the room. This is a young child. That sweet age, I see them 6 to 8 weeks, right there. But it could be up till about 3 months, where the mother comes in and says they vomit and it's across the room. It's projectile, all right? Literally. See a garbage can 10 feet away, turn the child when they're vomiting, it will hit the garbage can. That's how forceful this vomiting is. So what I do when I hear this, usually mom's holding the baby, I'll take my hand and put it right under that upper abdomen, underneath the xiphoid process. They call it a right upper quadrant. You're going to feel an olive. I call it a marble because it's hard. And that is the pyloric sphincter of the stomach. And that usually empties the stomach in the duodenum, okay? It's closed up. Any milk can't get into the body. So the child's good, eating, I'm hungry, eats well. All of a sudden, poof, across the room. What do we do for this? Well, the valve is shut. We need to do that pylo gototomy. Well, we just open up that valve, all right? We make it big, and it's usually all that needs to be done. Preoperatively, now remember, these are babies. So depending on how long it takes to get to the OR, of course, NPO, nothing more to eat. Give them that pacifier to keep them calm. And then, of course, start some IV fluids. Post-operatively, they start to feed them pretty quickly. They really do. They start giving them clear liquids, even breast milk, they consider clear liquids, but little bits and pieces. Cleft lip. This is when the lip looks like one of these here. One side, both sides, in the palate underneath the upper, they'll be open or not. I've seen palate and I've seen, the lip. I've seen both sides, one side. at birth, that, with it open, it's a lot for a parent to take. So I would always say, oh my goodness, your baby has such big feet. Or, oh my goodness, look at the hair on that baby. Or, wow, those got big eyes. I'll take that focus away because that's going to be fixed. Usually we fix that within only the lip part, 2 to 3 months. But just think about what the issues are. That palate open, you can't put your tongue up, you can't pronunciate. You're not going to have good speech development. That's why we do that about 6 to 12 months. So lip 2 to 3 months, palate 6 to 12 months. Now, before they get that lip done, and even after, they can't make that suck, whether breast or bottle. So a person who's breastfeeding, they have to literally squeeze their breast to get the milk into that baby, or they need to pump and put it in one of these bottles. This is a Haberman bottle. It is very soft on top, and the milk, you put it in the bottom, you turn it over, and that's soft. And you put the nipple in your mouth, and then you slightly, you push a little bit on that little barrel there, and they eat, and they think they're sucking and swallowing and they're breathing, and it's wonderful. Again, this will prevent them not getting enough nutrition and growth failure. Now we group together. Yeah, Gabriel, you have a question?
I'm sorry, I'm trying to do the chart as you're going. You said the cleft lip is at 2 to 3 months and the
Yes,
palate is
ma'am.
8 to 12,
6 to 12.
6 to 12. Okay.
Not a problem. So we group together esophageal atresia and tracheal esophageal fistula. These are no opening to the stomach, atresia, no openings, so the esophagus has nowhere to go. And tracheal esophageal fistula is an opening between the esophagus and the lungs, the trachea. That means swallow food down the esophagus, whoop, goes over to the lungs, and now you're aspirating. What would you think this baby would look like at birth with that TE fistula? What would happen is they have their own mucus. They swallow normally. I do all the time, right? That mucus will go down the esophagus into the lungs. These children will be coughing and gagging, choking, sputtering, turning blue. Usually, one of the first things that a nursery nurse does after they do their assessment is give them a little bit of glucose water because their glucose is dropping so quickly after birth. And that's when they're going to see this. And that's when the diagnosis is made. So at that point, either diagnosis, nothing to eat or drink. This child needs an IV now. Now, not only do they need an IV for that nutrition and fluid, they're also getting antibiotics. They're still swallowing their own spit. They're still getting aspiration pneumonias. So, head of the bed elevated, suction at the bedside, nothing to eat or drink, and IV fluids because they can't eat, and then antibiotics to help decrease the incidence of pneumonias, that aspiration pneumonia. Any questions with anybody? I'm sitting here sweating, not feeling great. I want to end the class for tonight. I'm just sitting here like going bonkers. Um, Sorry about that. I'm gonna send you a Kahoots right now. It's one I did Monday, and it's like 58 of them, and it goes over this again and again and again. But I think that you really got the Brooks of GIGU. That's what I wanted to give it to you, and I didn't want to send you anywhere else for it. I think that I can explain things in a manner that you really get it because I've seen all these things. And I think the way I describe it, you can get that visual. So, anyway, I'll be sending that to you. Remember, anybody who wants to meet with me, send me a message. Next week is going to be the reviews. So, the end of next week, you want to meet me. Thursday's a great day for me. Okay. So, if you want to meet me Thursday, I believe I do my review on Tuesday. If you want to do Wednesday before class, let me know. I'll review with you, for your exam, which will be on week 10. And then I'm going to start getting together all your HESI stuff. You guys will do great in the HESI if you do what I tell you to do. Okay? Thank you, everybody.
Hope you
Sorry,
feel better, Professor.
I appreciate it. Thank you.
Thank you. Feel better.